It's not the collagen. You've heard that explanation so many times, it's practically furniture in your mind. But collagen loss is systemic. It declines everywhere. If collagen were the reason your jawline softened, your forehead would be pooling at your eyebrows. It isn't. So collagen loss contributes to skin texture, yes, but it doesn't explain the directional pull you see along the jaw. It's not gravity in the way you've been told. Gravity is constant. It doesn't get stronger on your 40th birthday. Gravity has been acting on your face since the day you were born, and for the first several decades of your life, your jawline held just fine. Gravity didn't change, something else did. It's not the fat pads migrating. Fat pad descent is real, but it's a description, not a cause. Saying fat pads moved is like saying the furniture shifted. Okay, but why? What force moved them? And why did it move them in that specific direction? And it's definitely not because you skipped your facial exercises. Millions of people have never done a single jaw exercise in their lives and kept a defined jawline into their 70s. Others have done them religiously and watched the definition leave anyway. So if you've eliminated the standard explanations and none of them hold up as a complete answer, you're left with a question that most of the jawline industry never asks. Where is the pull coming from? That question changed the way I work with patients. Because when you stop assuming the face is a self-contained system and start tracing the actual anatomy, the answer takes you somewhere unexpected. Let me give the conventional model its strongest case first, because it deserves that. Dermatology and cosmetic medicine have built a coherent framework. Over time, the skin loses elasticity. The underlying fat redistributes. The bone remodels slightly, and the muscles weaken. Each of those things is true. Each is measurable. Each has solid research behind it. And if that's where you stop looking, the logical response is to treat the face with topical agents, with exercises, with procedures that target the local tissue. The model is internally consistent. It makes sense on its own terms. But here's where it runs into a wall. If the face is aging as a self-contained unit, why is the change almost never symmetrical? Stand in front of a mirror and look. Genuinely look. One side of your jaw almost certainly sits differently than the other. One side may have more softening, more descent, a slightly different angle. If collagen decline and gravity were the primary drivers, the change would be roughly even. Collagen doesn't decline faster on your left side. Gravity doesn't pull harder on the right. The asymmetry is the clue that the conventional model can't explain. And it's the question I want to follow. Your jaw doesn't float, it's anchored. And the anchoring goes much further than most people, including a lot of practitioners, realize. Trace what connects to the underside of your mandible, and you'll find the suprahyoid muscles. These small muscles form a sling under your chin, and they attach to the hyoid bone, which sits in your throat. The hyoid is one of the most unusual bones in the body. It doesn't articulate with any other bone. It's suspended entirely by muscles and fascia. Below the hyoid, the infrahyoid muscles run straight down to your sternum and your clavicle. So from your jawbone to your breastbone, there is a continuous chain of muscle and connective tissue. Unbroken, physical, present in your body right now. Try something. Swallow once, slowly. Feel the movement in your throat. That motion you just felt is the hyoid bone and its muscular sling engaging. The same chain that connects your jaw to your chest. You felt this connection 1,000 times without knowing what it was. A woman I worked with, mid-50s, very attentive to her appearance, meticulous about skincare, came in not because of pain, but because she'd noticed her jawline was changing faster on her right side. She'd been sleeping on her right side for 30 years. She'd been told it was collagen compression, sleep wrinkles, tissue creasing. When we assessed her ribcage mobility, her right lower ribs were significantly stiffer than her left. The side with less rib movement was the side with more jaw descent. That's one case. I'm careful about drawing big conclusions from single observations. But the pattern has shown up consistently enough that I stopped treating it as coincidence. People tend to think of the face and the torso the way you'd think of siblings who move to different cities. Related by origin, sure, but functionally independent, living separate lives. Unlike siblings who've moved apart though, these structures never left the same house. They share continuous tissue every single day. And when one is restricted, the other registers the tension immediately. Now let me pull at the second assumption, the idea that gravity is working locally on facial tissue to create that downward drift. Gravity is real. Gravity acts on mass, no argument. But gravity alone doesn't explain direction. If you hold a sheet of fabric at two corners and let it hang, gravity pulls the center down in a smooth curve, predictable, symmetrical. Your face doesn't sag in a smooth, symmetrical curve. It changes along specific lines, in specific directions, often more on one side. That means something other than gravity is determining the vector of descent. Tension determines vector. If tissue is being pulled in a specific direction by a structural force below, the displacement follows that force, not gravity's generic downward pull. The face isn't a sheet of fabric hanging freely. It's a sheet of fabric with strings attached underneath, and the tension on those strings is uneven. A man in his early 60s came to see me after a car accident. He'd fractured 2 ribs on his left side, spent months in recovery, and during that time noticed something strange. The jawline on his right side, the uninjured side, started to look sharper. Nobody had touched his face. He'd done no exercises. His physical therapy was entirely thoracic. When the mobility came back to his left ribs, the asymmetry evened out. His face changed because his rib cage changed. He wasn't looking for it. That's what made the observation so clean. Think about the way people approach a painting that started to warp. The instinct is always to treat the surface, retouch the flaking paint, smooth the canvas, apply a fresh coat. Unlike a fresh canvas where surface damage is genuinely about the surface though, a painting that's warping is almost always a frame problem. The wooden frame behind the canvas has shifted, and it's pulling the entire image out of alignment. No amount of surface restoration fixes a frame that's torqued. You address the frame, and the surface tension resolves because the canvas is no longer being deformed from behind. Your rib cage is the frame. Your face is the canvas. Treating the canvas while the frame keeps pulling is why results from facial protocols feel temporary. They are temporary. The restoring force of the fascial chain reasserts the pull within hours. I need to back up for a second because the scope of this connection is broader than the jaw. Your entire anterior chain is involved. From the inner arch of your foot, through the deep tissues of the inner leg, through the pelvic floor and the diaphragm, up along the pericardium and the fascia of the throat, all the way to the base of the skull. The deep front line. It's one continuous fascial highway, and the rib cage sits right at the critical junction where it transitions from the lower body to the upper body and the head. When the ribs lose mobility, and they do progressively from years of shallow chest breathing, prolonged sitting, the natural stiffening of costal cartilage with age, the fascia through this corridor shortens. It adapts to the reduced range. Tissue that isn't regularly moved through its full excursion loses its extensibility. The shortened fascia pulls on every structure above and below the restriction. Below, it affects breathing depth and pelvic floor tension. Above, it tensions the throat, compresses the hyoid position, and creates that chronic, low-grade downward pull on the mandible. The rib cage is the keystone. It's the point in the chain where restoration has the widest upstream and downstream effect. Let me qualify something. This will change how your jaw sits and how your anterior chain functions. That's a strong claim, so let me pull it back to what I've observed directly. Among the people I've worked with who had demonstrable rib cage restriction and visible jawline asymmetry, restoring thoracic mobility produced measurable changes in jaw resting position in roughly 7 out of 10 cases. That's not universal. 3 out of 10 had other contributing factors: joint pathology, significant bone remodeling, or restrictions originating elsewhere in the chain. So the rib connection is a major factor. It is not the only factor. Precision matters. Someone I saw last year had been doing gua sha on her jawline every morning for 2 years. She was consistent, she was dedicated, and she was frustrated. Temporary improvement after each session, then a return to the same pattern by evening, every single time. She described it as a rubber band pulling everything back. When I hear that language, something pulling it back, the question becomes, pulling it back from where? She didn't have a problem with her technique. She didn't have a problem with her commitment. The approach was addressing tissue at the end point of a chain while the origin of the tension sat in her lower thorax. 2 months of rib mobility work, she stopped doing the gua sha entirely. The jawline held. So 3 assumptions are on the table, and each one, examined carefully, has a gap it can't close. The jaw as independent structure assumption can't explain the continuous physical tethering from mandible to sternum. The gravity as local force assumption can't explain asymmetric directional descent. The facial treatment assumption can't explain why results don't hold. What remains when you clear those away is a structural reality. The rib cage's mobility directly influences the tension environment of the jaw through 2 feet of continuous fascial tissue. And the intervention that addresses the origin is a rib stretch, not a face exercise. Your approach depends on where you're starting. If you sit for most of your day and you've noticed your breathing has become shallow, chest dominant with very little lateral rib expansion, the place to begin is lateral breathing. Sit or stand. Place your hands on the sides of your lower ribs, fingers pointing forward, thumbs wrapping towards your back. Breathe into your hands. The goal is lateral expansion. You're trying to push your hands apart with the breath. Not a chest lift, not a belly push. A sideways widening of the lower rib cage. 2 minutes, 10 to 12 breath cycles. You'll likely feel stiffness, especially in the back and sides where the ribs meet the spine. That stiffness is what you're working to restore. Do this daily. Within 2 weeks, the expansion should feel noticeably easier. And if you pay attention to the tissue under your chin, you may notice a subtle softening of the tension there. If you're older and the rib cage has significant stiffness, the kind where a deep breath just doesn't seem to go anywhere, where the chest feels like it's wearing a vest one size too small, begin with supported extension. Roll a bath towel into a firm cylinder. Lie back over it, positioned horizontally across your mid-back at about the bottom of your shoulder blades. Let your arms fall to the sides. Breathe. The towel creates a gentle fulcrum that encourages thoracic extension and rib separation without requiring your muscles to force the range. 2 minutes. Let gravity and the breath do the work. Progress to the lateral breathing exercise when the supported extension starts to feel easy. If you're already active and reasonably mobile, but carry residual restriction, maybe one side of your rib cage doesn't expand as well as the other, or you can feel a band of tightness along one side of your torso. The intercostal stretch with rotation is where you'll get the most response. Stand with your feet shoulder width apart. Reach one arm overhead and side bend away from that arm, creating length through the entire side body. From that lengthened position, add a slight rotation of your torso toward the ceiling. You should feel the stretch isolate into the intercostal spaces between your ribs on the lengthened side. Hold for 5 breaths. Switch sides. Compare. The stiffer side gets an extra round. 2 minutes total. The rotation component is what accesses the deeper intercostal tissue that simple side bending misses. Whichever starting point you choose, the principle is the same. You are restoring the rib cage's capacity to move through its full excursion so that the fascial chain above it, the chain that terminates at your jaw, can lengthen rather than shorten. Here's what crystallizes when you hold all of this together. Your jawline is not a local event. It is the visible endpoint of a structural chain, and that chain runs through the most neglected region of most people's bodies, the thoracic cage. Every breath you don't take fully, every hour you spend compressed in a chair, every year that passes while the costal cartilage quietly stiffens, all of it shortens the chain that terminates at the underside of your jaw. The face is the last place the problem shows up, and ironically, it's the first place everyone tries to fix it. You didn't fail because you chose the wrong cream or skipped the right exercise. You were working at the end point of a chain whose origin nobody pointed you toward. If you're someone who needs to understand the structure before you trust the solution, someone who wants to know why before you're willing to try what, then you're exactly who I made this for. Understanding the chain is the first step to changing it.